Hi, I'm Larry Culpepper. In this presentation, I will discuss information related to 6 questions that are key to integrating into practice our current understanding of the cognitive effects of major depression. These include: how does cognitive impairment manifest in depressed patients? What are its biologic underpinnings? How can we recognize cognitive impairment? And how should we evaluate and monitor it? What about comorbidities, both medical and psychiatric? And finally, what can we do about cognitive impairment in our depressed patients? Let's start by exploring how cognitive impairment manifests in our depressed patients. I'll review the symptoms they may present with, their distribution in patient groups, and their course and impact over time, including with recurrent depressive episodes. Patients may present with a number of concerns that stem from cognitive impairments. For instance, that they lose their train of thought, that they have difficulty making decisions, that they procrastinate, that the brain is just cloudy. They may feel slowed in their activities. They also may have trouble with short-term memory. When we map these concerns onto the domains of cognitive dysfunction that we know occur in some patients with major depression, we see that they reflect alterations in psychomotor speed, attention, memory, and executive function. Core executive functions impaired in major depression include deficits in working memory, inhibitory functions for suppressing non-relevant brain activity, and cognitive flexibility. These in turn lead to impairments in higher order executive functions, such as planning and problem solving, and dividing attention between tasks. In addition to these cognitive functions, which by themselves are emotionally neutral, we also see deficits in hot or affectively laden cognitive functions. Now, the domains of hot and cold cognition are not separate and independent. We find that heightened responses to negative feedback can impair performance on cold cognitive tasks, and vice versa. Hot cognitive impairments include emotional processing biases. Depression is linked to how we attend to our environment even before signal processing reaches conscious awareness. For instance, on entering a room, the non-depressed individual will preferentially focus on those that appear happy or upbeat, while the depressed individual's attention is drawn to the sad, angry, or hostile person. There's also bias in perception. Depressed patients show enhanced recognition and a response bias toward sad faces and a decrease in response toward happy ones. They also tend to misinterpret expressions, for instance, perceiving neutral faces as negative. Depression also is associated with increased recall of negative over positive information and decreased storing of positive memories and increased storing of negative memories. When we look at groups, we find that cognitive deficits are concentrated in a subgroup of depressed patients. One large study found that moderate cognitive complaints were reported by 27% of depressed patients. These are complaints we would expect from only 2% of normal controls. Similarly, severe complaints were reported by 13%. A level that we would not expect in any control. Cognitive deficits may be present even in the first lifetime episode. A meta-analysis of first lifetime episode studies reporting on patients before treatment initiation found cognitive domains very broadly affected in depressed patients. We also find that cognitive deficits may occur even before the onset of the first lifetime episode in studies of patients at high risk for such onset. This high risk may be conveyed by family history, by early or recent stressors, and other factors. In some patients, cognitive dysfunction improves as patients improve with treatment. However, in a significant number, they persist even when patients attain remission to depression by conventional measures. Remitted patients continue to show impairments in executive function, memory, and attention very commonly. In a recent 3-year prospective follow-up study of individuals with recurrent depression, cognitive symptoms continued in a large number both during and between episodes when they were otherwise in remission. Here we see that 44% of the time between episodes they reported cognitive symptoms. Not only does cognitive dysfunction persist frequently between acute episodes, it also appears to progress as a function of the number of episodes. In one study, memory was reduced by about 2% with each subsequent episode of depression, at least up to 4 episodes. Cognitive symptoms also may lead to impaired functioning at work or in family and social roles. In one study, half of patients reported cognitive difficulties so severe that they interfered with their work. Next, what are the biologic underpinnings of these impairments? The origins of cognitive dysfunction in major depression likely include genetic influences, environmental stressors including early life, alterations in monoamine and glutaminergic pathways, and other factors. Patient age and other characteristics, and the severity and characteristics of the depression episode may play a part. While the cognitive alterations in anxiety disorders generally are less than with major depression, comorbid anxiety may play a role in depressed patients. Similarly, lifestyle may have an influence. We know that exercise is a major stimulant of brain-derived neurotrophic factor, or BDNF, and therefore those with sedentary habits may have less cognitive reserve and more prone to cognitive dysfunction in depression. Similarly, inflammation and conditions characterized by chronic inflammation may contribute. For some time, we've known that major depression is associated with smaller volumes in key regions that we now know contribute to cognition. More recently, we have come to understand that many of these regions interact in 3 functional brain networks involved in cognition. These include 2 cognitive control networks, the central executive network and the salience network, and these work in balance with the default mode network. The salience network evaluates the salience of events and identifies those requiring non-automatic response. It then activates the central executive network and deactivates the default mode network. Also known as the cingulate-opercular network, it includes the dorsal anterior cingulate cortex, the anterior insula, and the anterior prefrontal cortex. It receives strong input from the sensory and motor regions as well as from the autonomic system. The central executive network, also referred to as the frontoparietal network, provides executive control for the person's response. It includes specific areas of the dorsolateral prefrontal cortex and posterior parietal cortices. For instance, the anterior cingulate cortex is key to conflict monitoring and predicts task difficulty. It also interacts with the nucleus accumbens, which is involved in reward assessment and decision-making. The default mode network includes the medial prefrontal, medial and lateral parietal, and medial temporal cortical regions. It's active when there are not demands on the brain to respond to its environment. This includes activity with introspection and autobiographical memory. In depressed patients, it plays a role in rumination related to negative content. Now, with engagement of the sentinel network and central executive network, the default mode network normally deactivates. However, with major depression, deficits may occur in this switching and in the level of activity of the brain regions involved in these networks. The neurophysiologic dysfunction that occurs in major depression not only involves abnormalities in the centers constituting the cognitive control networks, but also decreased connectivity both within and between these brain regions and the three networks. Even when an affected individual appears to be functioning normally, brain scan assessment of brain oxygen consumption may show that increased metabolic work is required to maintain function. Now let's look at how we can recognize the cognitively impaired patient in routine practice. Certainly, we've already discussed the symptoms they may present with and the cognitive domains that this maps onto. For those of us who use instruments either to screen for depression or to assess its severity, they may include questions that can be helpful in specifically identifying hot and cold cognitive dysfunctions. For instance, the PHQ-9 includes one question reflective of hot cognitive deficits and two questions that may reflect cold cognitive impairment. The BDI, or Beck Depression Inventory, includes a number of questions related to hot cognition and one related to cold cognition. Now, how should we evaluate and monitor cognitive impairment in patients that we suspect it in? Self-report and objective assessment of cognitive functions correlate poorly. They both measure domains of cognition, but possibly different domains, and they both help explain decreased functioning. However, we have little experience or data to guide clinical practice. Our options include using brief objective and subjective measures to assess cognition and function. One difficulty is that we usually do not have a premorbid assessment, so interpreting whether an initial assessment indicates impairment in a particular individual may be difficult. For instance, a high-performing individual may still function within the normal range, although significantly impaired. With regard to subjective measures, we have two brief measures of cognition. These include the Perceived Deficits Questionnaire and the Cognitive and Physical Functioning Questionnaire. We also have a number of instruments, including the Sheehan Disability Scale, which may be used for assessing general function. Objective measures include a number of brief measures routinely used in neuropsychological testing. The DSST, or Digital Symbol Substitution Test, is perhaps the one that most broadly captures cognitive impairments. Other brief tests measure specific domains of cognitive dysfunction. The Perceived Deficit Questionnaire comes in a 5-question version and a 20-question version. Thus, in practice, we can use either or both depending on the circumstances. The DSST measures executive function, working memory, processing speed, and visual spatial attention. To use it, we instruct the patient to simply complete the blank boxes under each number consecutively using the digital symbols seen above. The correct answers within 90 seconds is the score, and it can be interpreted using age-adjusted standards. Now, what about comorbidities, both medical and psychiatric? Let's take a look at pain and sleep as examples, although we know that there are a number of other conditions that may have influence. Pain is processed through two parallel systems. There's a lateral system that includes the lateral thalamus and projections to the somatosensory cortices. It processes the sensory components and identifies the location, intensity, duration, and characteristics of the pain. It is not altered by emotional state, while the medial system, which manages affective and motivational aspects of pain, are. Depression leads to increased activation of this affective medial system. The anterior cingulate cortex is a crucial hub for affective pain processing, and we've already seen it's also a key hub for our cognitive networks. This may provide a mechanism wherein pain interacts with depression to influence cognition. Sleep disruption also can impair aspects of cognitive dysfunction. A meta-analysis of 12 studies demonstrated that insomnia results in moderate-size effects and decreases in episodic memory, working memory, retention and working memory, and problem solving. Other sleep disorders, such as obstructive sleep apnea, also may have quite significant cognitive impairments. Unfortunately, we have few data that evaluate cognition in depressed patients with sleep disruption. Other brain systems are also influenced by and influence cognitive status. The amygdala is the only component of the central autonomic network which connects directly to parasympathetic and sympathetic centers. It plays a key role as well in cognitive networks. And this may provide a mechanism for integrating autonomic input and responses with central executive, salience, and default mode network activity. When we identify cognitive impairment, what can we do about it in our depressed patients? We're early in developing and evaluating approaches to cognitive deficits in routine practice. That said, we can evaluate and monitor depressed patients, both during acute and continuation phases of treatment. For this, we can use subjective and objective measures of cognition and function that I've already touched on. Knowing the cognitive status may influence the initial choice of antidepressant or psychotherapy. For instance, patients that are significantly impaired may find it difficult to engage fully in cognitive behavioral therapy. With monitoring, we can adjust therapy if cognition remains unimproved in a patient. Patients who do not return to premorbid levels of functioning with remission of depression may benefit from cognitive remediation strategies, although we have limited data. Cognitive impairment also is important to consider in making decisions related to work. For instance, does the patient have the cognitive capacity to successfully return to work? Specific hot and cold cognitive impairments may create difficulties in our clinical relationships with patients and their relationships with our office staff. For instance, a patient that has psychomotor slowing and difficulty with executive functions, as well as hot cognitive biases, may find visits to our office overwhelming. If they arrive when the office's visit is busy, they may have difficulty understanding and answering questions from staff who are pushed for time. They may negatively interpret such staff and interpret their efficiency as not caring or being dismissive. They may conclude that they are a bother or the staff really have just given up on them. Consequently, we may find that they no-show at future visits. There are numerous additional examples, and these reflect the difficulties some depressed patients have in other non-clinical settings as well. The effects of impairment in attention and memory, for instance, may lead to difficulty in obtaining an adequate history and also may reduce treatment adherence. Hot cognitive alterations in attention and perception, along with negative biases, may influence patient focus on symptoms and real or perceived treatment side effects. At the same time, they may not recognize the positive benefits of treatment. They also may misinterpret patient education. For instance, they may focus on the possibility of rare adverse effects and conclude that they will almost certainly happen to them. In conclusion, we are early in integrating attention to cognitive function into primary care management of depressed patients. Still, there are strategies clinicians can use currently to evaluate patients and monitor management response. With attention to initial and persistent cognitive impairments, we also may alter treatment and improve outcomes, including promoting full recovery from depression.